Hello. I'd like to welcome to this session. We're supposed to have 3 people in the round table. We've got 2, although we only see Celine, one of the persons. We're waiting for Mark, who's coming back. He forgot his laptop somewhere. And I don't know if Uriel, who was supposed to be the first person. Ah, okay. Nice. So, yeah, we were waiting for you. You were so quiet. Yeah. Yeah, Uriel Moreira, if you can go there, you've got the presentation. We just have to wait for our technicians. You've got 10 minutes. You can begin. If you need anything, you can just pass. Okay, we'll have 10 minutes for each of the opponents, and then we'll have some time to discuss, to make questions. And we know Celine has got to rush away to get her airplane, but we'll keep tight to the timetable. It's all yours.
Okay, so good morning, everyone. My name is Uriel. I'm a statistician with the Belo Horizonte team in the Observatory for Urban Health in Belo Horizonte. And I'm also a fellow researcher in the Salón project, which is Salud Urbana in America Latina. And this is actually joint work with the researchers in the observatory. And Aline, which is the first author, couldn't be here, so I'm presenting in her stead. Just a little bit of background for the presentation. As I'm sure we all know, homicides are a major social public health problem because of its impact on the social structure and the impact across society and families in general. And they impact the entire population of the city, and particularly those living in vulnerable and more segregated areas. In Brazil, homicides have been shown to be associated not only with an organized, disorganized, and rapid urbanization process, but also associated with the wide social inequalities that are a hallmark. They are a very strong characteristic of the cities in the country, especially the largest ones. So our goal here is to evaluate the distribution of homicide rates in the metropolitan area, more specifically Belo Horizonte, and to see how the homicide rates are distributed according to age, period, and cohorts. And we're doing this across both vulnerable and non-vulnerable urban areas. So as for our methods, our outcome are yearly homicide counts, which we're capturing with the ICD codes, the ICD-10 codes X85 to Y09. And these are in the city of Belo Horizonte, as I've said, from 2002 to 2019. Our covariates here are just the population estimates from 2010, which we're using to compute the homicide rates. And these are aggregated in 5-year age ranges, which is the standard for the IBGE in Brazil. And we divided Belo Horizonte into slums, which are the informal settlements or vulnerable areas, and the formal city, which is the rest of the municipality. Okay, so the first thing we did was to do a descriptive analysis of the distribution of homicide rates. And we did this across ages, periods, and cohorts. For those that are not familiar with this kind of work, the cohort is defined as the age of an individual minus the period in time of that individual. So afterwards, after the summary statistics, we fit an age-period cohort model, which we're calling APC-IE here, because we're using the intrinsic estimator of Yang and co-authors in 2008. And this is essentially a Poisson model with homicide rates as the outcome. and an indicator for each age range, period, and cohort as explanatory variables. But because this model is perfectly collinear, the intrinsic estimator uses a simple but very powerful idea, which is to rewrite the indicator estimates along with the intercept to derive mean effects, deviations from the mean effects for each of the effects that we have, for each age range, for each period, and for each cohort. And because this is a linear combination, for those that are more into methods, we can also compute standard confidence intervals using walled approximations, wall type approximations. So as for our results, these are the homicide rates by age slums. By age in slums and in the formal city. And we see that consistently across our sample, homicide rates are higher in slums, as we might have expected. And specifically here for the ages, we see that we have higher homicide rates in the youth and the young adults age ranges, which are from 15 to 24 and 25 to 39 years old, especially in the males, but here we aren't stratifying by sex. This is by period. So in 2002, we start with high homicide rates, and this has a tendency of decreasing over the past years from 2002 to 2019. And this happens across the entire city of Belo Horizonte. And this is by cohort. As I've said, interpreting cohort effects is somewhat difficult because it requires a very deep understanding of the problem and a very good literature backing up. And this is Aline's specialty because I'm only the statistician, but we can see that consistently across the city, we also have cohort homicide rates higher in the slums than for an entire city. And throughout 1970 to 2000 to 1990, we see a very standing out peak in the distribution of homicide rates by cohort. So these are our main results, which are the IPC-IE estimates, and they're consistent with the descriptives that we just seen. These are for the formal cities. And the way to interpret each of these coefficients, as I've said, are as deviations from the mean homicide rates across all age ranges. So relative risk and relative risk smaller than 1 indicates that, for example, for the age range of 0 to 5 years old, this group has had relatively smaller homicide rates than the mean of homicide rates across all age ranges, and so on. So children had relative smaller homicide rates than the average across all age ranges, and the young adults and youth had a higher homicide rates, higher relative homicide rates than the mean of all age ranges. So we have the same interpretation for the period effect, and note that different from the descriptives, we have to aggregate each period effect into 5-year ranges because of the way the model works. So relative to the average of all the periods, we see that 2002, 2007, and 2012 had higher homicide rates than the average, and 2017 had smaller homicide rates than the average. For the formal city, we only have one statistically significant cohort effect, which was for the cohort of 1937. And these are the effects for the slums. We see the same patterning, although the relative risks are higher and smaller, because the relative differences to the mean in the slums are higher than those for the formal city, but the overall pattern is the same. And it is the same for the period effect. And we have a difference for the cohort effect, but as I've said, we don't have enough time to delve a lot into this, but we see that cohort effects for 1962 to 1997 were significantly higher in the slums, and we have the cohort of 2012 at a lower risk than the average of all the cohorts in the slums. So just to conclude our presentation here, as I've said, we saw that overall homicide rates were consistently higher in the slums. We see higher than average homicide rates for youth and young adults, and a smaller one for children. And we see that the homicide risk steadily decreased from 2000 to 2017 in both slums and the formal city. We had some significant cohort effects, and we think that these results, they're not only useful to better understand the distribution of homicides across age periods and cohorts and the city and its demographics, but they might also be helpful in informing public policy, because you can inform public policymakers to focus their efforts into certain groups. So that's it for me. Thanks.
Okay. Thank you very much. I'm going to ask the next presenter to begin, and I'm going to ask the audience to keep the questions in your mind, just to make sure that we keep in time, because Celine is worried about the timing. If I invite you to sit down, and then we will go to the questions. I've got a couple of questions for you. Mark, do you want to go next? Thank you.
Oh, it's up. Okay. Just testing. Good. Okay. Sorry for running out and running back. I mistakenly just somebody said that was Salón Actos in another room, and I went in there and uploaded my presentation and realized it wasn't. So I'm going to talk a little bit about a qualitative study on trauma and other determinants of health in Central American migrants in the Washington, D.C. area, which is an area that, and I'll talk about this in a minute, that has become, let's say, since the early 1980s, one of the top destinations in the United States for Central American migrants. And I don't think we need to dwell on this slide. Everyone knows that migration and migrant health is a huge issue and only burgeoning with current situations globally in terms of migrants. And so this study was an attempt to improve our understanding of health determinants for these migrants. And to do that, we conducted 75 life history interviews. Hopefully everybody's familiar with that. So these are extended chronological interviews, and there's a purpose for doing that. And we did those kinds of chronological interviews because we wanted to look at three interconnected domains: the home country experience, migration experience, and adjustment in the new country as one continuum. A lot of times in the literature, you will find data about home country situation, or data looking at migrants in the resettled country as as if there's a unique existence there, when typically there is not. So we wanted to look at that kind of accumulation. So here's a beautiful piece of art that illustrates that kind of cumulative domains. And the hope, so part of the hope was to not only collect the data, but to legitimize that three-domain transnational model of health determinants, and look at how that played out with this particular population. So you can see from the data there that in the Washington, D.C. area, particularly in some communities in the state of Maryland, which is one of the bordering states to Washington, D.C., there is a large population of Central American immigrants. And we have at the university, at George Washington University, I have a center called the Avance Center for the Advancement of Immigrant and Refugee Health. So that's what we did this project through that, and also in affiliation with a group called the Center for Social Wellbeing and Development. So I won't go into it in detail, but the history of Central American migration to the United States generally, but also to Washington, D.C. is fraught with many political and other issues. There were not many Central American migrants prior to 1980. They came following the civil wars, and because of the political context in terms of the U.S. relationship with authoritarian governments in Central America, it was very difficult for migrants to get any kind of legal status. And you can look at the data and see migrants from other countries, and it's much easier to get political asylum and other kinds of statuses. Until later, when there were some congressional legislation to fix that. What then happened, of course, is that in that kind of liminal space where these migrants are trying to exist, trying to make a living, there was some involvement and the startup of a number of gangs, MS-13, 18th Street, which then were, in a sense, exported back to Central America. And the migrants that are coming in recent years from Central America are actually fleeing violence from the gangs that were the result of the initial sort of exporting of gang members in the U.S. So just as a real, this may or may not make any sense, but this is Washington, D.C. We had an intervention and a control community that we've used in a number of intervention studies. This one was qualitative, so we did not have a comparison community, but ours is the community that we were working on for this is in the upper right-hand corner there. And here's some obligatory pictures of kids in the community. Have to have these. This is the community that we're working with. These are some youth that are in some of the programs we have. So again, we used a life history interview, and we have a long time collaborations in the community, and they helped us considerably with recruiting. Recruiting at this time being very difficult because of the political environment, but we did manage to get our sample of 75, and then we analyzed those using a software called QSR in vivo, looking for common themes, particularly around those domains of health determinants. So the total sample was about 60% female, about 40% male, 18 to 57, but 57 was an outlier. So most of them, the respondents that we talked to were in the sort of young adult or 30-year-old kind of range. Mostly from El Salvador and Guatemala, and some from Honduras, and just one from Nicaragua. I don't know if you can see this table. Is that visible to anyone? Maybe not. Okay, well, I'll go over this a little bit, but we looked at several domains here. They're sort of captured in this table of what we found in terms of the number of migrants that we interviewed who expressed a particular kind of risk or social determinant of health. And you can see that there is a considerable number of immigrants who experienced violence or other stressors in the home country and violence en route here. And some of that violence I can't even begin to capture in this short presentation because there are some fairly long quotes. But so in terms of reasons for leaving, not surprisingly, again, one of them was imminent violent victimization, and the other was poverty with little available opportunity to make a living, and both of those are clearly intertwined. And so most of it was gang violence. Some were fleeing from gender-related violence, and those migrants would often pay a lot of money, somewhere between $5,000 and $20,000 is what we were getting for payments to take them across the border. So this is you can just see this is one quote from a woman who is talking about her situation in San Salvador, where she says it's very, very ugly because imagine witnessing how they killed a person and how, no, I have no words to tell you that, well, how I and my son were witnesses of how they killed a person in a minibus where we were traveling. What can I tell you? No longer. It was not life, because every day, every minute you heard a shooting, and we had to close windows, doors in fear of going out to the corner or out into the street because you didn't know if you were going to come back. And there's another, a young adult female here who was, again, talking about the killing, even killing of students, if you don't pay rent, which is extortion basically from the gangs, or even if you looked the wrong way at a gang member, you could be targeted. The other quote down here is from someone talking about in San Pedro Sula in Honduras, where the gang issue is particularly acute. And she was talking about just the whole difficulty in moving from territory to territory. So these kinds of things are regular experiences, in addition to just, the economic constraints and inability to find a way to work and feed families. And there was a distinct contrast, and I don't have quotes here, but there was a distinct contrast in many of these migrants about how things used to be, or how they love their hometown, the beautiful trees, the farms, so on and so forth. And they can't do that anymore. So this sort of myth that they're just coming here to the US is not accurate, because many would like to have been able to have a living in their hometowns with in those situations that they had. So yes, and the violence again and poverty are interconnected. Sometimes it's because of that extortion. You're trying to run a business and you can't because the extortion is there. And then a lot of the respondents also experienced some severe violence and other health issues when they were coming up through Mexico, which is typically how people got here, on a train, walking, other things like that. And if you know your geography is in your head here, that Salvador and Honduras, that's the Iron Triangle down there. It's a long way. You have to get through. And I have worked on that border down there, and it's not a friendly environment, not at all. Very difficult. So you have a lot of migrants that are perishing from just the conditions in the desert, and hunger and other things like this. And that isn't even to mention the witnessing or being a victim of sexual assault. Typically imprisonment for ransom, because a lot of the cartels in Mexico have now gotten involved in the migrant trade, so to speak. And so they will often, kidnap migrants, hold them in a house or somewhere else, and hold them for ransom, so that they have to go back to their coyote, back to their smuggler, and see if they can get more money. So again, I don't know if you can read this quote. If you can't, hopefully we will be able to see the slides, and I will read some selected quotes. But this woman is talking about being, sort of held in captivity for 5 months. There's another woman that talked about something like this, and I don't have a quote because it's too long, but I'll just give you a nutshell. She was held by cartel members who then split up the migrants they had into to different cartels. So she got split up into a small group that was being taken by the Zetas, which is one of the harsher, if that relative term even makes sense, but the harsher cartels in Mexico. So she said that they were being threatened with their organs being taken out and used as commerce if they did not pay up more money. And at one point, she said that it was a small group of about 8 migrants. They were in a house, and there were 2 or 3 cartel members who were getting very drunk and playing Russian roulette. So they had to kneel, and they just point the gun at their head and shoot. So one woman who had a lot of courage, she spoke to the person next to her, and she said, look, this is a dirt floor. The next time they walk around, grab a big handful of dirt, throw it in their eyes, and then let's run. And that's what she did. And so the migrants fled after doing that, which is really incredible. So when the migrants that we interviewed came to the US, there were varying degrees, not surprising, of being able to make that adjustment. Again, adjustment into a situation where even if you are on a path to get legal status, a green card or other legal status, it's a very long period of time. And of course, during that time, you are not technically documented, you are in process. But so some people that came, found the situation better because they did have access to school, there was transportation, and there was sometimes work opportunities. On the other hand, I will wrap up. There were other, situations, of course, where there were several of the migrants who had serious and severe PTSD from their combined experience. And this is just a quote from one of them. And so, and you know, some of the usual things, no social networks. There were, you know, people worried about getting picked up and so on and so forth. So I'm going to skip this one and just go to just the conclusions here. So again, domain one, the home country domain, people are fleeing from gang violence, domestic violence, gender-based violence, poverty, lack of opportunity. At the same time, many of them express this kind of almost poetic love for their hometowns. The migration experience was very difficult for most. Some of them had health problems. One woman had a baby on the way, a lot of violence victimization when they came here to the US, high living costs, the legal environment, the legal climate, and at the same time, many were able to get work. So just as a comparison, and I'll finish off with this, we did a quantitative study with youth that were in some of our programs, and you can see that we found very high rates of youth, 60% or so, who said that they had faced violence in their home country. And almost a quarter of the sample had faced immigration violence. So these are sort of triangulating quantitative data, giving you a picture of that. And so the gist of what we were trying to do again is inform services and other providers that are working with these populations that you need to think of that entire transnational spectrum and how it plays into this. Okay, close to the time there.
Thank you.
All right, thank you.
Thank you very much. I'm going to ask Celine to get here. I'm assuming we haven't got Dr. Kamrun here because he didn't. Okay, so we've got 10 minutes to listen to Celine and then we'll have some questions.
Yeah, thank you very much. So thank you for the opportunity to present this work. And I think that we represent the three presentation, different, a nice panel of different approaches, different levels, the level of individuals, level of group. And now I will dezoom a lot with a global level, showing different interests of urban health issues in different continents. So this research is a part of the ISUH main. It was a big research led by Carlos and Giselle in ISUH, and in this research we provided different materials for to search what could be the future urban health agenda for WHO project and for together with United Nations Habitat, and what could be so where to put the efforts in different domains and in every continent. So the project was organized like that, with at the center ISUH, different continents, and more generally, I made a larger survey on all the continents. So the goal was to see in different regions of the world what could be the place or the domains where to strengthen the activities of urban health, what questions are translated into action, where are the gaps. And so we had a different work package, and in this organization, I gathered some data and made some analysis of network collaboration and to identify all the actors existing in different continents and where they are working and where are the gaps. And so we collected, we developed this project in four different steps: collection of data, preparation of the data cleaning, third, the analysis and the visualization. In the data collection, we started defining with Carlos and Giselle different contextual words so about urban and the outcome of disease and health. So we made a large web mining all over the world with the two conditions, and we collected more than 2 million of text. But when we passed to the process of treatment, finally we had 123,000 text to analyze, and so it is different kind of documents, and we identify more than 5,000 actors. So I do not have time to explain all the steps, but we go now to the results and interpretation. So we started in 2000, and you see that, of course, the literature grew a lot, and also all the possibility of document in the web with all different NGOs, private actors, and so on, publishing on the web. So we differentiated for different period of time, 2000, 2010, 2011, 16, 17, 19, and we isolated 2021 for the COVID period. And here I've put different colors according to the thematics that we identify. So we developed a topic modeling, which is a machine learning process to identify at each period here the main topics composed by different words. So it is a semantic analysis, and so you see here in pink all the health topic really concentrated to health. In blue, the regional and urban policies. In green, the environmental topics. And so you see that with time, the environmental and regional and urban policies develop a little bit more compared to the small reduction of only health issues and urban health. And what we were interested actually is to see how far the planning and environmental issues are integrated in the health issues in cities. And then we took by continent all the different documents, and we treated making a network analysis of the topic modeling. So you have here the topics appearing in squared, and in yellow you have the different words that we call lemmas, terms that compose the topic, and in blue you have all the actors. And so we see whether some topics they have many actors or not. And more, the nodes are central in these graphs, more they are central in the vision, you know. So here for Africa, for example, we have at the center, mental, pregnancy, medical research. And so all urban environment are very peripheric. So you see spatial planning, water management, traffic issues, and on the bottom, you have food risk and environmental issues as we identify as urban environmental, and some specific issues that we found only in Africa as development and food and sexual risks. Then in North America, we have very different organization. And here you see a group of environmental issues, climate change, urban health management, and environmental context, and network modeling, which is more theoretical, and the specific thematic. Yes, is about women rights, and here many, well, one main actor, which is a very big association on women rights. And for Latin America, we have two poles with water and accidents, and a specific topic on rural alcohol. And for East Asia, Here you see that it is very central. All the central topics are about urban and environment, and also on the top, regional economic growth, social housing, and some specific issues on social policy design and rural and urban social care. Then Middle East, you have different poles here on urban environmental, and the specific issue is about refugees, which is not surprising. And finally, no, it's not finally, but there is another one. In Oceania, very interestingly, all the urban environmental issues are very central compared to the other one, and indigenous space are very specific. And yes, the last one, Europe, is here. It is more periphery. You see the urban environmental issues, and the specific thing is about the stress and economic regional inequalities. So in conclusion, you see that according to the different continents, it was very, very quick here, but according to the different continents, we have different integration of urban planning and regional and environmental issue in the health questions. And specifically what we saw is that in Oceania, for example, or East Asia, environmental issues are more central in the approach of urban health, which means that they are more integrated in the whole urban health issues to treat and to make actions in the different cities. And my interpretation is also that, for example, in Europe or US, where it is more peripheral, I think that the institutions are older and they treated more with different silos the topic of health. And so it is more difficult to integrate better urban environmental issues into the health questions. So the limits of this study is the lack, I would say, of integration in the project. We worked 4 months only on this program. It was not enough really to exchange with all the interviews that were made by the other member of the project. But the data, we gave the data to the ISOH, who is supposed to prepare it to make it open access. I know that the report will be ready soon in WHO webpage, and also we wrote with this material a chapter in a book in Springer, The Future of Livable City, that will be published soon. And I take the opportunity to present again the MOOC we are preparing just for a few months, the MOOC Massive Open Online Course, Healthy Urban System, that we presented yesterday, but you have some flyers here, or you can ask to Mariana, who is in the room, and because I've got to leave just after this presentation. Thank you.
Thank you very much, Celine. Thank you for this meta-analysis information you gave us. So we had 3 ponents. We had some more local research on urban health, and then we've got a general point of view. So we had these global and local points of view. So we've got this global research, which is perfect, having the things seen from outside and from inside. So thank you very much. I'd like to ask the audience if there are questions, comments, both the audience and our colleagues, please. Yeah. If you can just wait so that you've got a microphone.
Thank you. I'm Lucy Mize. I work for the Agency for International Development. I have 2 questions. is the last presentation, the book coming out very soon? Because it sounds like it has a lot of data that we could, or ideas we could use in some of our designing. That's to Celine. And then Mark, is your work only to inform domestic policy, or do you think it could be used to inform some of our international work?
Yeah. To answer your question, the report will be published, I think, very soon in the WHO website. I think it's in few days or weeks. Yes.
Yeah, no, the answer to your question is that we absolutely looked at this as not just domestic oriented. We looked at this as something we were trying to develop. This was a qualitative, you could call it a phase one step of the research, and we were developing some quantitative instruments that might follow from this if those domains and some of the things that showed up held across different migrant populations. So absolutely. And there is an article in Global Public Health on this. So it has the methodology and a much more fuller description of the results with the expressed intent of a global relevance. So.
Okay, I still here. Any other question or comment?
Can we ask our own question?
Yes, of course. We're all free.
Very interesting, the entire panel. So thank you for having me on there. I just wanted to ask you, is it when you were looking at those social networks across continents, and how did you sort of capture or think about the variability within any continent? So if you're looking at North America, of course, you got the US, you have Canada, and you have Mexico, all of which have different systems for linking any of those domains. So how does that work? East Asia, it's probably variable too in that sense. So when you were thinking in a continent sense, how did that play out?
Yes, of course, the scale is very important, and we could relaunch the things at the national level or even at the urban level with maybe different data. But well, it was just to catch a little bit the differences, and where they were more complementary. You will see in the report there were many people, they make very deep interviews, and it is very complementary to that, and they speak more about their national context and so on. So well, we answered to the demand, which was to work by continent, and so we did that. But you're right.
I've got a question. If there are no questions in the audience, I'd like to ask Uriel, did you make an analysis related to gender? Have you got data on that part?
Yeah, we actually got data on gender and race, and we did a lot of descriptive analysis with them. But fitting in an APC model for this type of data, you have to be very careful to not stratify the data too much, because if you got something like 16 age ranges and 4 periods, and you have a lot of cohort effects, so the data is naturally very already stratified. So if you end up with a lot of zeros, you might end not capturing anything. We're trying to adapt the method because the model is essentially a regression with indicators, and the intrinsic estimator, it just picks up the difference between each effect relative to the mean effect across all age ranges, periods, and so on. And so we're trying to adapt the method to use the same data for the same model with all strata. And we do one effect for females at each age range, for males at each age range, for blacks in each age range, and for whites in each age range, and so on. So we can use the same data set and not have to stratify.
Okay, thanks. No, I was making this question because I presume you want to really know where the problem is coming from in order to make policies to try and approach this challenge, and then knowing exactly, because this is the next question, have you got an hypothesis of why this age range is the one that, I mean, those people are having these problems because maybe they're not studying, they're just in that period in between. Have you got an hypothesis?
You mean about the age effects of the cohort ones?
Yeah, the age effects.
Yeah, we have a lot of research, especially in the Observatory for Human Health, relating to homicides in males and females, and especially focusing on that youth and young adults population. In Sauerball, we have a paper which is about to be published, and overall, males are in this age range are 10 times more at risk for homicides than females. And if you look at this age range relative to the all other ones, it's about 7 times the number of homicides for all the other ones. So this is sort of already known from the global context. There are a lot of WHO documents on this, but specifically our research also backs this up, that these age ranges are more at risk for homicides. And this also makes sense because of the exposure to violence, especially in those vulnerable areas. We have a lot of young males that are exposed to toxic masculinity. They are isolated and segregated areas. So you have a lot of more crime going on. So you also have more homicides and so on.
Thank you. I think Mark wanted to say something. I know Celine wants to leave. Yeah. Do you mind, Celine, if we stay here, you can leave just to keep it going for some minutes. Have a nice trip.
Yes. So I just in terms of the policy question you're talking about, did you, were you able to glean from the data a transitory phase? In other words, at a certain point, maybe around, let's say, age 14, 13, this is a point where the data go from low violence rates to quickly transition to higher violence rates. And the reason I'm asking, just because we also do some youth violence prevention, firearms prevention work, and one of the things we're focusing on is the identity development phase in adolescence, and where the norm, or norms related to involvement in violence become part of the adolescent identity development process. And it's somewhere in that 12 or 10 to 16-year-old range. And then after that, once it becomes normative and part of an identity, then the actual perpetration shoots up. So I just wondered if you saw that transition. Is that what you focus policy on prevention policy?
Yeah, I think this actually gives us a very good research idea because, well, the problem with working with Latin American data is the data. The age, I mean, we have homicide counts that are continuous in age. So you have exactly the day that the person was born and exactly how many days they were old at the time they died. But the population estimates are aggregated in 5-year age ranges. But there are some demographic methodologies that you can use to sort of interpolate them out that we're using for other parts of the project. So maybe you can build a sort of continuous homicide rates curves across age ranges. This would be a very interesting research idea. Yeah. And I mean, not only a research idea, but also very good for focusing policy and developing that identity for homicides, because this is really important.
Okay, thank you. I've got a question for Mark. I'm sorry, I like making many questions. I was wondering if, because you've got lots of personal situations, are those facts that push these people out from their countries, are they being repeated somehow in these new neighborhoods, in these areas? Are they finding some of those problems that are moving to these neighborhoods that are like really isolated?
Yes, they are. And it really, not a surprise. It really varies, by the particular landscape. But there are some, one of the quotes actually I had there was one of the women, the same thing she feared in Salvador, she feared here. She feared that if she saw any authority, that she would somebody would yell at her and say, run, run, run. And she thought the same thing here for months. Even though, so there's the actual situation, but there's also the interpretation of the situation, because they're coming from a setting where a certain, a landscape looks a certain way, and it may or may not be that way actually in the US. It's really varies by urban context. It just so happens in the community that we were working in and have worked in for a while that over the last probably at least 10 years, there's been a huge influx of NGOs. I mean, when we started working in that community, there were 4 Catholic sisters. They lived in some apartment buildings. They provided the social services. And there was another little building that was very dingy. You had to go up an elevator and was one day a week. People spoke Spanish. And that's very different now. It's because a lot of NGOs have moved in there. And so there's a much more, you could say, the term community efficacy. There's a higher degree of community efficacy there just because of that. And so that probably cut down on some of that, but still it varies. I mean, no surprise 4 years ago in a certain administration, I mean, the atmosphere was not only heightened by the legal environment, but by the encouragement of other people to act in a vigilante sense, or, go to a day labor center and stand across the street with cameras and other things like that. So they are finding some of that. But the helping resources are in some communities are increasing, and they do offset that to some degree.
Okay, thank you. Is there any other comment? Yeah, thank you. Thank you.
Hello, good afternoon. Thank you for your presentations. Gordana speaking from Macedonia. I have a question related to the maybe community empowerment programs in the US. I'm curious about what type of programs do you have for the empowerment of immigrants, whether they're predominantly NGO-based, what type of funding is provided, and also whether the state is also creating some special programs for immigrants. Thank you.
Again, it really varies by the political landscape in the US. I mean, we have had, working in this one particular community, we have had several interventions that were community empowerment interventions funded by the Centers for Disease Control, because they have a division of violence and injury prevention. So that is at the federal level. I just have one now funded 2 weeks ago from the National Institutes of Health, and that is part of the President's Gun Violence Prevention Initiative, and that is also a community collaborative. But we had, there is an institute at the National Institutes of Health called the National Institute on Minority Health and Health Disparities, and they, a lot of their funding has been centered on trying to develop community level interventions, most of which do involve some form of empowerment. I mean, ours was focused on youth, the one that we had that was funded by NIH before. And we absolutely had, I mean, we trained kids in advocacy and communication, and we were trying to increase attachment to the community, because from our own data, investment in the community was low because people just felt like they cannot stick their head up at all because of the legal environment. And so even if there was a housing problem or asthma generating conditions in apartments, they didn't want to say anything. And so people then just figured that in this area or this neighborhood, there's, we can't really do anything about anything. So we did try to, and I know we're certainly not the only one. There is one major NGO that has gotten started as a day labor legal advocacy organization and has become a highly trusted and even politically potent NGO in that neighborhood over the space of 10, 12 years. So. Yes, of course. Yes. Yes, churches too. That is a complicated environment, no surprise, because in this particular community, again, it varies by community, but for Central Americans, there's the Catholic Church, and then there's a multitude of evangelical Protestant churches, which are, range from a storefront that have a congregation of 30 people to, something much bigger. And we have a COVID project that we're working on, and we have, as part of our community engagement coalition there, we have 3 churches, 2 of which are evangelical and 1 of which is Catholic. But it has not been that easy, actually. I mean, the churches did not, for example, necessarily want us to directly approach people about, let's say, vaccines and things like that, because they didn't want to potentially lose parishioners. Because in some of the churches, there was a chunk of parishioners who were skeptical. And so the churches have traditionally been very helpful. And we, in previous interventions, had worked with the Catholic diocese in the Washington, D.C. area. But it is a little bit of you have to negotiate that one a little bit carefully, but yes.
Okay, a last question, if you want. No? Okay, so we're just in the limit of time. I'd like to thank the 3 ponents for all the research you're carrying out, and thank you for sharing it. That's how we make things improve. And well, I hope we can meet each other out for a while and chat in an informal way. Thank you very much for attending this plot on research on urban health, and welcome once more to the city of Valencia.